The next speaker, the topic is Non-Cardiogenic Shock Pharmacotherapies, the Standard of Care in 2023. And this will be delivered by Dr. David Feldman, who is the Director of Clinical Services, Heart, Lung, and Vascular Institute, and Director of Advanced Myocardial and Circulatory Support at Newark Beth Israel Medical Center. Dr. Feldman.
Well, good afternoon, everybody. I'm honored and humbled to be asked to be here again, so I want to thank the organizers for an opportunity to be here. From a show of hands, can anybody tell me, raise your hand if you have read all of the AHA, ACC, HFSA guidelines that were republished 18 months ago and then revamped again about 12 months ago?
No.
Right. Let me tell you why. It's 835 pages. And you all have asked me to talk about the highlights. That would be 85 pages per minute if I was to stay on schedule. I'll do my best. Fortunately, I've been accused of saying this before, I'm the fastest talking Southerner you ever met. I'm going to actually allude to this one other time. I will say y'all like 50 times. I can't help myself. I don't have any disclosures. I have shamelessly ripped off almost all of these slides in one format of another because I thought it was actually important for the preservation that they come from the ACC, AHA, HFSA. And in order to do this, I also ripped off David Letterman because I wanted to give you a top 10 list. How do you make something not interesting at 85 minutes per minute? Okay, here we go. All right, you got to talk about this. And so I wanted to talk about level of evidence, and we all have heard this like 50 times, but if you're anything like me, I had to hear it 100 times before it got through to me. So this is how I equate it in my simple brain, a plain speaking Southerner. Class 1 is you should. Class 2A, you probably should. Class 3B, maybe you should. Might ought to think about it, okay? Class 3, should not, don't go there, okay? Now, I'll actually allude as well because, in fact, this is a mixed group that, in fact, things you want to stay away from is anything that's in red for the boards and anything that's on Class 1, you definitely should know for the boards. When you're getting towards the end, whether it's critical care, internal medicine, cardiology, or your nursing boards, your NP boards, your PA boards, all of them are going to focus on 1s and 3s. Level of evidence is those compelling large trials, A's, where there's just tons of stuff that says, please do that. Clinical trials for B are those where, in fact, there's very compelling data, but not humongous trials with, like, God's submission with billions of data points. And then, lastly, you have a C, which is expert opinion, which is where most of your shock stuff is, most of your VAD stuff is, et cetera, et cetera. Never put a slide on here that, in fact, you can't read in less than 30 seconds. Can't read it. At the very end here, if y'all want these slides, my email is there. I will send anybody the slides that they want them. And as a consequence, all the slides that look like this, I am now going to race through except to say, okay, here's all the stuff you should do for those stage A patients, stage B patients. And let's face it, y'all, I'm talking to a room full of people who take care of shock for a living. You don't need from me to hear, please start an ACE inhibitor. Okay, so here's the diagnostic algorithm. And one of the things that became new and unique with this is that, in fact, you now have patients with heart failure with a preserved ejection fraction, those that have a reduced one, and now we have the medium ones, or moderately reduced, and the moderately reduced is 41 to 49%. It's probably worth noting, too, that the ones that are reduced, the EF is less than 40%, not to be confused with a lot of the ICD guidelines that are 35%. All right, talking point number 1. For patients who have newly diagnosed stage C heart failure, you should start an ACE inhibitor, an ARB, or an ARNI. It says you can start them in any order now. Each agent should be up-titrated to maximum dose, okay? Beta blockers should be tolerated when the patients are dry. Takeaway, okay? from a clinical standpoint. ACE inhibitors, ARBs, ARNIs, they should be used when patients are wet, not a beta blocker. That'll decrease your ejection fraction, attenuate that whole cardiac power index calculation, and make your patients worse. Alternatively, you start a patient on an ACE, ARB, or ARNI while they're actually dry, they have an increased bicarb. This is when you say they're intolerant to ACEs, ARBs, and ARNIs because, in fact, as a provider, you started it at the wrong time. This is the SLDT2. You can see this is HPEF, for preserved, and you can see these are patients with an EF of less than 50, greater than 50%. And you can see here, it actually has the green, yellow, and then the two Bs, which are those might ought to think about it. Treatment for patients with moderate, okay? And what you see here is that, in fact, it's saying diuretics needed. I want to focus on that for a second and come through that. As needed, y'all, okay? And why? Okay, let's talk about that for a second. Everybody knows the guidelines have suggested only 3 beta blockers. There's 4 if you actually are LA and you want to talk about levosimendan, you can add nebivolol to this group for Europe. But it's carvedilol, metoprolol, succinate, not tartrate, and of course bisoprolol. Another very chic one to be used in Europe. Terrific drug, doesn't lower blood pressure as much, is 20 times more specific in terms of receptor affinity for the beta-1 receptor than metoprolol succinate. But one of the things that was a takeaway from this is that now they're saying ARNIs are the preferred agents if the patients will tolerate them. Okay, and this should be checked within 1 to 2 weeks. I'm not going to tell you how to start that because everybody in this room already knows that. Summary point number 3, diuretics should be added again as needed. And let's not call aldosterone antagonists diuretics. They are, but that's not why we start them in heart failure. We start them in heart failure for neurohormonal antagonists. When they say diuretics, they're talking about loop diuretics. They're talking about the ability for you to decongest patients or to keep them decongested. The rest of the numbers are on there. I'm not reading any of this to you all for the sake of time. Might ought to think about it. This is what I do want to show you. There is no loop diuretic that's ever been demonstrated to make a difference in a positive outcome related to patients. So if you were leaning on a loop diuretic too hard, you are treating the icing as opposed to the cake related to the actual disease and the process. Managing the phenotype, making patients decongested, improving their quality of life, decreasing their intracardiac filling pressure is all important. But whether it is retrospective or prospective data, the higher the dose of the diuretic, the more likely chance is that your patient is going to die. Okay, so point number 4, after initiation of a beta blocker, an angiotensin receptor blocker, an ARNI, you should add an aldo antagonist. Where I do think, and I said that you shouldn't think of this as a diuretic, I would say that in fact that aldo antagonists do have the ability to actually augment what would otherwise be ideally the best and lowest dose of a loop diuretic. Using SGLT2s, remember this is not just for diabetes anymore. It's going to be pretty soon just about for everybody. You can see what the recommendations were, and the 2023 guidelines with the executive summary is basically from 2022. Moving on to number 5 on the top 10 list, persistently patients who are symptomatic who are African American, therapies related to the utilization of hydralazine and nitrates. I love this because it's the one time where we've actually picked a minority group and everybody has extrapolated this to the rest of everybody else. I think that's cool in my opinion. And in addition, despite maximally tolerated blood pressures, looking at a heart rate greater than 70, other things should be considered, including ivabradine. And remember, the caveat is that these patients who have AFib or flutter in the past do not do well with this drug, and it is related to rate. And remember, of course, that we call normal sinus rhythm 60 to 100. I will tell you that, in fact, I am not comfortable with any patient in my office having a heart rate of 90, and every patient that has a heart rate of 55 who otherwise is walking, talking, has organ perfusion, I'm okay with that, with them being bradycardic. Hyperkalemia, these are all things that we know. But I think it's important to say that, in fact, it was very bougie there for a period of time, that for right-sided heart failure, Dr. Berghoff was talking about this, and we all just, and especially when we start talking about VAD and transplant here, when we see RV dysfunction, let's just lump on a phosphodiesterase inhibitor. Remember, y'all, there is no inotrope or pressor that isn't known to increase mortality. So let's not do that. Probably not great for the boards either. Other things to consider, GDMT, of course, is goal-directed medical therapy. This talks about the utilization of other medical therapies worth considering. Ivabradine is the only 2A. The other ones are might-oughta. Summary point number 6. In addition to considering therapy optimization during hospitalization, this is key. I mean, a lot of us, the medicines you start in the hospital, you will find that these patients will stay on that exact same dose of medicine until you see them back again. The modern world does not have time for a lot of practitioners to up-titrate this, and so you've got to see these patients back. The utilization of being up-titrated every 2 weeks is essential. The utilization of echocardiogram for following up is key. I wanted to mention that after hospital discharge, if you're going to have an AHA-approved program, which is a center of excellence, those patients need to be seen back in 5 to 7 days. They can be seen by anybody who's in primary care or a cardiologist. By the way, primary care also includes pediatricians and OBGYN. These are the CRT recommendations, falls under the category of I can't read that in less than a minute, move on. And here is all the really cool stuff that's coming out about mitral clip, mitral regurgitation, and all that old stuff that's going on. Here is the key takeaway for that. On the boards, they're going to give you this situation, they're going to make it very compelling, and they want you to go, oh, I'm so progressive now, I've actually decided that I'm going to actually intervene before this heart is dead. Except the patient will be asymptomatic. And when they do that, the answer is you continue to keep watching them. It's when the patients are symptomatic that you actually move forward with these patients. Okay, these are additional therapies, which include surgical revascularization, transcatheter edge-to-edge MV repair, wireless monitoring, and we'll, for the sake of these issues related to proprietary information, just stuff out there. But I think that what's really important about the hemodynamic monitoring from the outside is when it's done by a third-party company as opposed to your heart failure team, it is much less successful. All right, number 8, improved EF is those that have an EF that has gone above 40%. And now there was always this debate for many years, and I'm not sure that's still been remedied. I think one of the best papers I've seen recently was by Clyde Yancey. But these patients got there because of your hard work. It's like a patient who's on 3 meds who has a blood pressure over 110/70 and says, I'm not hypertensive. Or the diabetic who now has a hemoglobin A1C of 5.5 who's on 3 meds and a little insulin during the day, who goes, I don't have diabetes anymore. Yes, you do, okay? And stay on what actually got you there and don't take it off unless it's broken. Too much stuff on there, right? So this is how to treat amyloid. Here's my take. Send your amyloid patients to somebody who, if you don't like taking care of amyloid patients and you don't have this slide memorized, send them to somebody who does. Amyloid heart disease has new recommendations, and serum and urine monoclonal chain should be checked, scintigraphy is there, gene sequencing is there, but now we really have therapy for this, as well as anticoagulation. I think the big concern I still have about some of these therapies, really expensive. Well, that's another very busy slide, but I stole it from the ACC, shamelessly ripping that off, and that's other stuff we should consider. But what it does is it talks about the groups specifically of those that have iron deficiency anemia, those that are hypertensive, types of sleep apnea, and other stuff you should do for unique groups of patients, making it patient-centered. Finally, this is the last slide, and it shows that, in fact, those that actually, this is now a segue for the very rest of the next 2.5 days, which is that if your patients have failed all this, you need to refer them to somebody in this room. A heart failure specialist should be considered for those patients, and it gives a nice list that I think that would be very good, because I see that outside practitioners are asking for this information all the time. You want to refer them when they have the 3B and 4. You want to be respectful, of course, and make sure that, in fact, you're a good partner. And all of these things on this list, including an EF of less than 35%, your patient's been shocked, they keep coming back to the hospital, they have renal insufficiency, they have a white count of 3, they have creatinine of 5, escalating diuretics, low blood pressure, high heart rate. All these patients would benefit from seeing somebody in this room. I want to thank you all for listening to me today.
Thank you, Dr. Feldman. Great talk. And thank you for let us cut on this 183 pages we need to read.
It's a podcast world now, right? 835 pages into 10 minutes.
Yeah. So I have a question. All of us agree that it's very important to follow these patients and do titration, but I think most of my colleagues and me will be on the same point that sometimes it's very difficult. And sometimes it's very difficult for patients that come to our centers from far away. So do you use telemedicine in your practice? And if you use it, what is your take point on that? Because I think it will be a great tool, especially for us. We live in a big city, but we have patients that live 3 or 4 hours away. Or do you partner with the primary care physicians and those centers to make sure that this titration is made?
That's a great question. COVID changed everything for everybody, and a lot of those things weren't really good. A few of them were good, and one of the things that in fact has changed is that insurance companies all of a sudden decided that doing remote visits was ethical, and that in fact we weren't billing needlessly for that. I think that when your patient lives, and I'll give you an example. I had a portion of my practice that was in Minneapolis. If you're looking for advanced medical therapies and you live in North Dakota, South Dakota, Montana, Wyoming, and Idaho, you need to go to Minneapolis, Denver, or Salt Lake City. There are some bad programs, but the point is people are traveling thousands of miles. Okay, so then it boils down to when your patient doesn't come in, are they non-compliant, or is it just you're not being realistic? So I favor the latter. We're not being realistic. I like to partner with a primary care doctor. I think that remote monitoring for some of these patients, because remote monitoring works best for the ones that are in the middle, right? I mean, if they're stage D and they're New York Heart Association class 4, the WEDS is elevated. You don't really need to have them download that. And if they're very stage A-ish, but they have a decrement in their ejection fraction, not very helpful. So I absolutely endorse the ability to do it by remote monitoring and partnering with primary care. If you all didn't know, most insurance companies, and I'm not really clear why, they will actually, there's a difference between calling the patient as a physician or a provider and having a video visit. And video visits are cheaper for patients than phone calls. They wind up with a larger part of the deductible. So it costs them money for a phone call.
Hey, Dave. One comment, one question. So one comment is we have a PharmD clinic that we can send our patients to, and they'll do it over the phone and video monitor and up-titrate every 2 weeks. So we get them on GDMT. And then my question is if your patient, you get them on quadruple therapy, low dose, the EF recovers to 45%, do you still try and titrate to target doses, or do you leave them at the dose that they recovered on?
So let me make sure that I understand the question by repeating it. If you're up titrating their meds, and while you're up titrating their meds, their ejection fraction recovers, do you still keep pushing down that line? That's a great question. So let me say, in part it would depend on why it is the patient's ejection fraction was attenuated. We just alluded to COVID. COVID was, in part related to myocarditis or blah, blah, blah. And so that may be something that's self-limited, and so you would think about anticoagulation the same way, and maybe I wouldn't actually continue to up-titrate. Alternatively, I think what it's really telling us is that, in fact, Dan in the front row, I subscribe to phenotypes being important, but even more important is I think we need to be looking behind the scenes. And everybody who has a recovered ejection fraction, I think we can all agree they are very likely to have a problem again during their lifetime. Not if, but when. So I will titrate them, but perhaps not as aggressively, because when we talk about maximal medical therapy, isn't that really a soft line anyway? Because it's maximal medical therapy comma, as tolerated by that patient. So if I'm pushing up their medicines, Joyce, and they still have a blood pressure of 130, I'm going to keep pushing. If they're at 110/70, they've recovered to over 50%, and they look righteous, I'll leave them there, and I'll get rid of the loop diuretic completely.
Quick questions, David.
Dr.
Brilliant
Narula.
talk, 50 pages per slide. It was amazing. So the two questions are, one is like when we go to the additive therapy, it might take us almost a year to come to the maximum doses of all, right? So is that preferable, or there could be a possibility that we start all the drugs in the small quantities together and accrue the benefit of all the pathways, which are all diverse pathways. None of the pathways are working through the same pathogenetic mechanism. So that is one. So would that? So again, I'm just trying to bring the Milton Packer versus Javed Butler kind of hypothesis. The second question, like in the improved ejection fraction category, we know that we have specific suggestions. But those where there are clearly reversible causes, possibly clearly reversible causes, quite like postpartum cardiomyopathies or viral myocarditis, non-genetic type of non-ischemic cardiomyopathies, those type of situations, is it really helpful to continue with the same suggestions as we have for the HEF improved EF or even for the HEF MREF type of protocols?
So 2 questions from Dr. Narula, both difficult and challenging ones, so I'll try to tackle them anyway. So the first one it can take you almost a year, and should you actually consider the uptitration of multiple medicines at the same time? Well, there was some allusion earlier in the talk about AI, and I think that people love algorithms, and I think that ultimately the right answer, Dr. Narula, is that there's a lot of wisdom that actually still goes into medicine where there's still an actual art. And so I think you find that the more seasoned the practitioner is, the more comfortable they are with the uptitration. I think that the unsaid recommendation from AHA, ACC, and HFSA now is that if it's taking you a year, you probably need to see them more often. I think that's something when you're talking about cooperating with other providers as well, that's particularly important. And I've seen some of Jerry's notes, he's very good at this, is the ability to actually say, hey, this is what I'm going to do today, this is what else we need to do, et cetera, et cetera, et cetera. So when they're seen back by another provider, I never have my feelings hurt when they go, my primary care doctor up-titrated my carvedilol. I went to my OBGYN, and it said in the note from the last time I saw them, if the blood pressure is blank, please go up on this next time patient seen. And that helps it move faster because, when you're talking about people not recovering, I think that waiting a year for CRT or some of these other therapies to be implemented, I think we could actually save lives by moving a little faster. That's challenging, but I think that's what we need to do. The second question was
the postpartum.
So the ones who are postpartum cardiomyopathies or the myocarditis. My problem or my concern about that is that the diagnoses that you started to articulate are frequently diagnoses of exclusion, which means in my particular case, I wasn't smart enough to figure out what the hell was wrong with you, so I put a label on you, okay? That being said, if this was your family member and you were to flip it around because, statistics and numbers are directly related to the circumstances you're in, if there's a 10% chance that you're wrong and this postpartum cardiomyopathy actually existed beforehand, or, especially with non-viral cardiomyopathies where in fact you really have no idea and you start, pulling back on stuff, are you okay with that if I said that was your son or your mother or your loved one? For me, I'm going to go back with these are patients who, even if they phenotypically have resolved on a molecular level, on a genetic level, on an mRNA level, on a lysosome mitochondrial level, they have not necessarily recovered, and they are just waiting for another opportunity. So I will remove things that I don't think are necessary. If patients report that, in fact, their quality of life has been attenuated, I will back off on those medicines. What do, y'all? We make people feel better, we make them live longer, we tell them the truth, okay? So if I can back off, I will, if they insist on it.
No, I mean, I do the same thing practically, right? But that is why I qualified it viral myocarditis, non-genetic, because now we've started to look into more of these than those which eventually develop the dilated cardiomyopathies after myocarditis. They are more likely to have a genetic background rather than not having a genetic background.
And if it's a genetic background, I think, if you actually identified an abnormal gene, I think these are ones that you're self-selecting out already when we talk about who are you trying to prognosticate, who is going to get worse in the future. I think that's very telling for me. I would, love to have a genetic basis for, making a determination for these patients.
Thank you.
Excellent. Thank you very much.